Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Happy New Year, and welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. We have a special Hot Topics episode today, where I'll be joined by two guests to discuss impactful articles that have been recently published. Today's topic will be reproductive health. Joining me is Dr. Whitney White and Dr. Lisa Sammaritano. Dr. White is a clinical pharmacist at the Birmingham VA Medical Center. She's a researcher and also a patient with rheumatoid arthritis, so she brings both her personal and professional perspectives to our discussion. My second guest is Dr. Lisa Sammaritano, professor of clinical medicine at Weill Cornell Medicine and an attending physician at the Hospital for Special Surgery. She's the lead author for the ACR 2020 Guidelines on Reproductive Health in Rheumatic Diseases. If you'd like to learn more about these guidelines, please listen to episode 13 of ACR On Air. And now, on with the show.
Whitney and Lisa, thank you for being here and welcome to the show.
Hey, thanks for having us.
So Whitney, let's start with you a little bit. Tell me how you became involved in your interest in reproductive health and rheumatology.
Absolutely. So when I was first diagnosed with rheumatoid arthritis, I talked to my rheumatologist and I said, hey, I'm 32 years old. I'm really young with this disease that potentially can be debilitating. And I don't want it to be that for me. I want to be a way for me to actually help other patients and to be involved in research and moving things forward as far as patient care goes and patients like myself. He heard that and he said, hey, I have some great groups for you to get involved with and offer your patient experience, but also your training in pharmacy just to help us do that very thing, to improve outcomes, to make sure that patients have the right information and the resources. And it really just took off from there. And being a woman, and I had a child prior to my diagnosis, and then I've had two children since then, and just kind of working through all of those things, being a mom, a working mom with rheumatic disease and managing just life with that, and also making those choices with what medications to take throughout that whole process.
Yeah, so that's certainly a complicated topic, and certainly, as we'll discuss, is something that's confusing for both patients and for providers. And tell me a little bit about Arthritis Power and Creaky Joints and what they do and how you became involved in those organizations.
My rheumatologist shared with me about Creaky Joints. I'd never really heard about it before I was diagnosed, and it really became an exciting thing for me to get involved with. I learned that it was really a platform for patients to share information with each other that was scientific and evidence-based, but really just that real-world experience of what they were struggling with and some of maybe the wins that they had. You know, this really worked well for them. But what I was most excited about too was the research arm of it, that they really wanted to push the research platform forward and use real patient experiences to do that. So it was really cool to get involved with that, with Arthritis Power, which is a way for patients to track, but be a part of a database where they can track their symptoms and their medications and have almost real-time data to provide to their rheumatologist to see how their disease is being managed or maybe could be managed better, because it really is hard to recall a lot of that information on a day-to-day basis. So like I said, it's been very exciting for me to be a part of Creaky Joints as one of their patient governors, but also involved in their different research initiatives throughout my disease experience and really from the very beginning.
And yet you have a really interesting background, not only because of the fact that you're a patient with rheumatoid arthritis, but also you have a background in you're a pharmacist.
That's right. Yeah. And I've always kind of said it's good and bad to have that training, especially when it comes to medications and making those decisions, because sometimes too much information can be difficult to really know what to do with. So, but it really has provided, I think, a unique experience for me to help bring that training to the table and kind of pair it with the patient experience. And for me personally, it's really helped me have a lot more empathy for patients, regardless of the disease process that I'm helping manage. But just to really kind of see that whole process through their eyes, it's really, impacted me in that way as well.
Great. And I guess as part of Arthritis Power in Creaky Joints, you took part in this manuscript that we'll be discussing. The title is great. It's Tough Choices, Exploring Medication Decision-Making During Pregnancy and Lactation Among Women with Inflammatory Arthritis. So the first author is Meret Biru-Talabi, and this was just recently published at ACR Open Rheumatology in July of 2021. And so what specific questions did you guys want to answer regarding medications during pregnancy?
Yeah, I think it really came from our patient groups that we talked with, which I was included in some of those discussions early on, and trying to sift through those questions and those things that patients really struggled with and who they really went to for advice and information, whether it be different providers, a rheumatologist, their primary care provider, their OBGYN, or pharmacists maybe, or different resources that are available on the web, trying to really tease out where are they getting information, who do they trust the most to provide accurate information, and what are they really struggling with as far as making decisions about medications that are safe or not safe in pregnancy and lactation. And so it was really clear that there was a lot of mixed messaging, that they were getting different answers from different providers, and that really caused them to be confused and really have pause about what really is safe for me to take. And I think part of that, we showed that made them potentially not take medications that were safe for them and potentially compromise control of their disease because they didn't have good understanding about the safety of those medications.
Yeah, I guess there's a fine balance between sort of giving medications to controlling disease, but not wanting to have any adverse effects on the growing fetus.
Right.
Right. But then if you stop medicines, maybe your disease will flare up. And certainly that's also not good for the fetus. So there's this balance. Lisa, how do you manage that balance when counseling patients during pregnancy? Sort of, do you take medicines or do you not take medicines?
Well, I think, the most important thing is to realize that the decision will be different for different patients. So some patients are so fearful, even if it's a very, very low risk of an adverse outcome from a medication, they just will refuse to take it. And yet another patient may look at it more in the way that I do as a physician, that it's a very unlikely adverse side effect, and that on balance, controlling disease will do much more for both the patient's safety and the success of the pregnancy. So I do my best to explain things to the patient and try to get a good sense of where they're sitting in terms of that spectrum of decision making. And if they don't like what I'm suggesting, then we try to work out a compromise where we still do the best we can for them and for the pregnancy. One of the things that I found really interesting in the article, Whitney, was that it mentioned that there was more confusion and more disagreement among physicians sort of after 2012. Am I remembering that right? And I think that's because we know more now, but not everybody knows what we as rheumatologists know. And so I think that in the past, patients were told, stop your medicines, go on prednisone if you have symptoms. And yet now we realize, well, that may cause them to have premature rupture of membranes. That may cause them to have some intrauterine growth restriction, aside from the diabetes and the hypertension and the progression of joint disease and maybe, deformity. So I think that the fact that there's a bit more confusion now, in a way, is probably just part of the process. And as we move forward, hopefully all of the different physicians and the patients will be more on the same page as we have, more and more evidence, I think, that this is the safest way to manage inflammatory arthritis and other rheumatology disorders during pregnancy.
Yeah, and Whitney, is that the case? Did you find in your study that some women felt that no medications were safe in pregnancy?
Yeah, I think you're still going to have that number of patients that are just super conservative about what medications they take for whatever reason, or maybe they heard about a bad experience. I know for me personally, I had the option to change medications because I was on one at the time that was not safe to take in pregnancy. And my rheumatologist gave me the option to change to a different medication or stop it and see how I did. And I actually chose the more conservative route to stop my medication and then just take it kind of week by week. And fortunately, I didn't have any trouble during my pregnancy and was able to stay off of my rheumatology medications for the duration and for several months after I delivered. But that was like Lisa was saying, a personal choice. Everybody's different with what they choose to do. But certainly my rheumatologist was definitely an advocate of, we have these safe alternatives that you can change to. And the most important thing, like she said, is that your disease is well controlled. And that was certainly important to me as well.
I would say, just as you mentioned, Whitney, one of the things about rheumatoid arthritis, as opposed to some of the other rheumatology disorders like systemic lupus, is that we do have this opportunity of a patient developing a pregnancy-induced remission. And, even though I think today's studies suggest it's not as widespread as had been initially thought, it's still almost half of patients will have a pregnancy-induced remission, at least to some extent. And that does allow us a lot more latitude. I find that patients with systemic lupus or other disorders where we don't see that kind of remission may not have the same flexibility in terms of making that choice and seeing how things go.
And Whitney, how does a patient make those decisions about whether or not to continue their medications? You mentioned that they discuss with the rheumatologist, but do they get information from other places as well?
Yeah, I'd like to think that every patient has really lengthy discussions with their rheumatologist like I did. And my rheumatologist appreciates that I like data and I like numbers. And so he would explain it to me, show me the data and walk through all of it so that I was more comfortable with what the actual data was. But I think a lot of patients do get that information offline, which many of those resources can be reputable. Many of them are not. Many of it is just anecdotal experience from other patients, which can be good or bad. And so I think we've done a lot of work to try to increase the evidence-based resources that are out there, but there's still a lot of opportunity. And that's why it was really exciting to work with the Reproductive Health Initiative to try to kind of broadly help get the word out, if you will, about the safety of the medications for patients and providers.
Great. I think the article mentioned that, about 80% of women discontinued drugs that were not toxic so that they could have continued, had they wanted to. And I guess as we discussed, for some people, they discontinued it because they feel that, they just don't want to take any drugs. But other people might have had the misinformation that that specific drug was toxic. And it seems like it's not just the patients that don't have the right information, it's also the providers. And it must be so challenging receiving different opinions from different providers. I think the paper made such a great point about, patients, general practitioners saying, stop all medicines, the rheumatologist saying, continue all medicines, and the OBGYN saying something in the middle. So it must be incredibly confusing. And I think this paper really brought that to light, and how confusing it must be for patients when different people have different opinions about what's the right thing to do.
Exactly.
So it seems like overall there was sort of inconsistent information, both from patients, that patients maybe didn't know which medicines were safe and not safe. It seems like they were also getting different information about the safety of various medicines from their different providers. So how do we fix this, right? Like what are some ways that we can sort of bring this information and advance the field and, educate everybody?
I think exactly. And I think that this paper and one of the other papers that we'll talk about makes the point that it's not enough to educate rheumatologists. We did the reproductive health guideline. That's great. Are the OBGYNs reading it? I don't know. And I think we really have to educate more broadly. And when you get to the topic, for example, of breastfeeding, then you have to link in the pediatricians. And until we sort of reach all of the players who have a role and a voice in terms of a woman's pregnancy and then the health of her newborn, I think we're going to have continued conflicting opinions.
That's unfortunate.
Well, I think we have a ways to go, but we're getting there.
Yeah. I think certainly the guidelines are certainly a big step forward to improve knowledge. So speaking about improving knowledge, the next article that we should discuss is called Improving Knowledge of Lactation Compatibility of Anti-Rheumatic Medications Among Providers Who Care for Patients with Rheumatic Disease. This was written by Brooke Mills and Bonnie Burmas, published at ACR Open Rheumatology in January of 2021. So I guess first stepping back, discussing lactation, what are the benefits of lactation and why is this concerned about, encouraging women to breastfeed their infants?
There are benefits for both the mother and the infant in terms of health, including long-term health risks for the infant. So I think that, it's unequivocal that the benefits for most patients are there. And so women who choose to breastfeed, and there's a lot of encouragement and support given towards this, should be able to without worrying about being on a medication that limits their ability to do that. But the problem is, just as with pregnancy, women sometimes will have a hard time believing their doctor when we say that the medication is safe. And it only takes one person in their life, a sister, a friend, the woman down the street, to sort of cast doubt on that. And then, I think that every person who has a child is, very concerned about, of course, doing the right thing for them. And a mother who's breastfeeding her baby does not want to think years from now, if her child has a problem, that it was her fault. And I think that it comes back to that maternal guilt, if you will. And so I think that it's very hard if women get, different messages. Which is why I think, the ACR is making an effort to have, easily sourced patient information, creaky joints, all of the patient-directed information from, highly regarded places, I think can make a big difference in this, because I think people feel more secure if they hear the same thing from different sources. It's one thing for your doctor to tell you, but no matter how much you like your doctor, you still may have a tiny bit of mistrust. And so I think hearing it from other places is very important, and hearing it from other physicians. And that's really comes back to this paper and talking about the differences in knowledge among rheumatologists versus other physicians. And the fact that, as the authors did, giving physicians a simple card that lists the medicines that are okay actually made a change that was enduring over 5 or 6 months in terms of the doctors remembering. And I'll be honest with you, really, probably all you have to do is give them a quarter of the card with just the medicines you cannot take, because there aren't that many, there really are not. Most of them are okay, but it seems more difficult than it is, I think, sometimes.
I think this article was really interesting because, as you mentioned, Lisa, it showed the lack of knowledge about the safety of many of the anti-rheumatic drugs that we use during lactation. So they surveyed rheumatologists, they surveyed pediatricians and they surveyed OBGYNs about whether or not they thought specific medications were safe or not safe. Nobody did very well. I think rheumatologists overall did better than pediatricians and OBGYNs, and that's probably because we use these medicines much more often. But as you said, Lisa, the finding that they didn't know so much at the beginning, but you give them this little card that says, these medicines are safe. These are the medicines that patients should not be taking during lactation. And that actually greatly helped to improve knowledge of, the safety of these drugs, even 5 months after the intervention.
I wonder, if it would be helpful to give our patients these cards to hand out to their doctors. I can tell you just anecdotally, I had a patient with significant lupus, but well controlled on azathioprine and hydroxychloroquine during her pregnancy. We talked multiple times about plans for medication during breastfeeding. And I told her she could continue both those meds. And yet, after she had the baby, she came back and she told me that she stopped the azathioprine because her pediatrician told her to. And, I didn't know what they were saying, so I had no way of countering that. So I really do think it might even be useful to have them give it out to their doctors, because we can't reach every patient's other physicians. Maybe the patients would be appreciative of something like this.
Yeah. What do you think, Whitney, of, a card for patients, coming from the ACR certifying, these are safe drugs to take during pregnancy and sharing that information with other physicians?
Absolutely. I think of kind of that new mommy packet that you get a lot of times at your OBGYN when you're expecting, and it's got a whole lot of information about what to expect in pregnancy. But usually in there is a list of medications that you can take and you can't take. And so, wouldn't it be cool that if we made sure that information was accurate as it relates to the rheumatic disease drugs, but also maybe rheumatologists should start giving a little packet or, something similar, getting that correct information out there. And kind of to Lisa's point, with lactation, and moms are taking their babies into the pediatrician after birth at pretty frequent intervals, 2 weeks, 4 weeks, 8 weeks. So they're seeing that specialist a lot more, that provider more than they're seeing the rheumatologist. And that's where they're getting that information. They're asking those questions to a provider that should know the right answer and that they trust. So we've got to make sure that information is consistent. And so I think it's a great idea to give that information to patients, and who it comes from. I'm not sure the best one, but I think the rheumatologist, because that's what patients have said is my rheumatologist is who I have the most trust in and who I really want driving the ship of my care, even though I have all these other specialists on board.
Yeah. And certainly, we want patients to make their own decisions, but we want them to make decisions based on accurate information, right? A patient may still decide to discontinue their hydroxychloroquine during lactation, and that's fine. But as long as they understand that they could continue hydroxychloroquine, and that is, it's considered safe during lactation. So we just want patients to have the accurate information about these medicines, and certainly all their other providers, so that we can all give patients the same message. And with that message, patients can certainly choose as they most see fit. Great. And then the last article that we wanted to discuss today, it's called Improved Pregnancy Outcome in Patients with Rheumatoid Arthritis Who Followed an Ideal Clinical Pathway. And this is by an Italian group led by Alessandra Bortolizzi and colleagues, published in Arthritis Care and Research in February of 2021. Lisa, do you want to tell us a little bit about sort of this paper and what they were looking for?
Right. Well, I think that, it's a very interesting way of trying to show that following the guidelines, following, the recommendations that most of us as rheumatologists give our patients for pre-pregnancy, pregnancy, and of course, postpartum care, that it really does translate to a difference potentially in pregnancy outcome. And, interestingly, I do, again, in terms of systemic lupus, it's been long understood that there are really significant risks for adverse pregnancy outcomes for those patients. And for many years, patients with rheumatoid arthritis were just considered, general population, no issues. And then over the past 10 to 15 years, there have been a number of cohort studies that suggested, even our patients with rheumatoid arthritis can have adverse pregnancy outcomes if their disease is very active or if they are, for example, on high doses of corticosteroids. And so that is something that we've come to understand. And I think that really that message is true for every rheumatology disorder. Active disease is not good for the mother or for the pregnancy outcome. And so this looks at it rather than with a cohort, looks at a large healthcare database. And the group looked for certain specific measures that they characterized as their best sort of quality indicators in a sense. And they included things like having an appointment with the rheumatologist, checking anti-Ro and La antibodies, which are present in a significant proportion of rheumatoid arthritis patients, checking antiphospholipid antibodies, not taking methotrexate during the pregnancy. I mean, these are all sort of seemingly very obvious, but when it comes to care across, a country or a large group of women, not necessarily so obvious. But they do show that those patients who sort of meet those criteria have better pregnancy outcomes. And it is hard to know, of course, whether it's more related to medication or compliance or whether patients who are quiet are just going to have better pregnancy outcomes. But I think it does support what we as rheumatologists have been telling our patients and trying to tell other specialists that, planning for pregnancy, having quiet disease when you conceive, changing your medications before you get pregnant rather than, after. All of these things are better in terms of controlling the mother's disease and preserving her health, but also in preventing adverse outcomes such as earlier delivery or smaller babies or things like that. I will say that I do, when I counsel my patients, I try to emphasize both aspects of this, both a woman's own health and the state of her inflammatory disease, but also the impact that it has on the pregnancy outcome. Because just as, you found, Whitney, in your study, there are women who think, I don't care if I'm in pain, I'll just suffer. I don't want to put my infant at any risk. I'll stay in bed. I'll be in pain for 9 months. Yet that is not the best thing for a developing fetus. And I think it's important that we sort of get that message across. And I think that's part of the message that this paper supports.
Yeah, I think it was interesting that, when they looked overall at women with rheumatoid arthritis, they had worse pregnancy outcomes than the general population. But when you took those patients with rheumatoid arthritis that followed the guidelines that you mentioned, Lisa, those patients had equivalent outcomes as the general population. So maybe, what that suggests to me is that, we can work with our patients to try to really optimize their pregnancies and hopefully have pregnancy outcomes that are just as successful as if they didn't have rheumatoid arthritis or whatever other rheumatic disease they have.
Yeah, I think that it also makes the point, coming back to the Tough Choices article, where there were some women who did become pregnant on methotrexate, right? It really makes the point that reproductive health in general is an important topic of conversation, and we shouldn't wait until a woman says, I want to become pregnant. We should be thinking, oh, she's on this medication. Let me tell her, even if it's for the 5th time, you are using contraception, right? Because I think that is a very important aspect of healthcare that some rheumatologists may not think is their job, but it really is, because everything that we give our patients impacts this area. And so we need to sort of start from the beginning and be involved in that.
Yeah, Lisa, I remember the first time we met and did an episode together. I think one of the take-home points for me was asking every woman of reproductive health the question, are you planning or are you thinking about getting pregnant over the next year? And then that can, generate those discussions. Are you on using contraception or not? What are we going to do about your medicines? And I think that was a great question that I've definitely used over the past year to try to sort of bring up those topics for patients. Whitney, I wonder your experience about as a patient with your rheumatologist, how often these issues are brought up in clinic.
Yes, I will say I have an amazing rheumatologist, and really from the very beginning. I mean, like I said, I was 32 years old when I was diagnosed. I already had one child. That was one of the very first questions that he asked me. I think from my very first appointment was, hey, tell me about what your plans are for more children. And so we talked about that. I'd recently had my second child. He was about 8 weeks old when I was diagnosed. So I was going through kind of the lactation part with him. And then at the point that we were ready to have my third child, we, had those discussions again. But I think at almost every single appointment when I would see him, he was like, has anything changed? Are we thinking we're going for number 3 yet? So let's talk about that. And of course, making sure I had appropriate contraception on board, knew the risk with all that. So he was wonderful to always have that as a forefront, knowing that that was something that was, important to me, and that we weren't done having children at that time. I've been able to tell him, I think we're good now. He did a really good job. And I think to reiterate that was one of the salient points that came out of some of that initial work with the patient groups. And I'm happy to hear that it's the ripple effect of have your rheumatologist ask that question at the appointment, being proactive with family planning and asking those questions before, you have a female patient, or, sometimes with male patients as well, before you have maybe an unintended pregnancy on a teratogenic medication. So I think that's great. It's great to hear that that's starting to make an impact.
Great. And I think your point, Whitney, well taken about male reproductive health, which is another topic that was discussed in the ACR reproductive health guidelines. And Whitney, I wonder, in your role as a pharmacist, right? So when patients get their medicines, they have this whole list of side effects that comes with it. And I'm sure no medicine, even hydroxychloroquine, if they read the fine print, none of these medicines are going to say safe for pregnancy. Is that right?
Yeah, I almost hate those medication guides, and maybe I shouldn't say that as a pharmacist, but yeah, it lists every single possible side effect that you may ever have. And it's very overwhelming. It's very daunting. Who would want to take a medication with all of that stuff? And yes, oftentimes, unless it's a medication that is definitely unsafe in pregnancy that they're taking, it may have an auxiliary label on the package, or it may have that in the medication guide, but it's not going to provide a lot of detailed information about that. It will just say, not safe in pregnancy, but everything in between, there's not the level of information that a patient needs on that to be able to make a decision about a medication.
Yeah. And are there resources that Whitney or Lisa, where patients or providers can look to find accurate information about, the medicines used in pregnancy or lactation?
So I would say the package insert, or what we call monographs sometimes, of the medication should have that information in there. And then sometimes you have to dig a little bit more to see the studies that have been done specifically. So that's available to prescribers for that. And then there's other resources like LactMed, which is helpful for lactation. And I'm blanking on the other resources. Lisa, remind me. For
Mother to Baby, which is the Otis registry looking at pregnancy effects and following for outcomes, birth defect outcomes. So I think there are good online sources. And I think that those sources do try to give you the appropriate perspective. But even so, I think it comes back to the physician to sort of take the list of 100 potential side effects and put them into perspective as best you can for your patient. And that, I'm sure, varies, from rheumatologist to rheumatologist. Some may think that none of them are significant. Others may think that they're so significant that they don't want their patient to take it. It's very challenging. That's where I think something like creaky joints, here sort of groups that can present information that is valid and evidence-based. I think there's a lot of room for more of that on the web.
Great. Well, this has been a great discussion about reproductive health. I think, we discussed 3 very interesting articles. I think what I got away from it is that, there seems to be still a lot of confusion from patients and physicians about what are safe medicines during pregnancy, during lactation, but that, hopefully we can educate both patients and providers about, medicines that are clearly safe and clearly unsafe, and provide this information in a way that patients can use to make their own decisions about, how they want to manage their pregnancies and lactation. And, with the thought that, as you mentioned, Lisa, active disease, is not good for a pregnancy. It's not good for the fetus. It's certainly not good for the woman. So there are costs to having active disease. It's not so easy as just saying, I'm not going to take any medicines and that's what's best for my baby, because having active disease is certainly not a good thing for anybody. Any parting comments before we finish today's episode?
I would just say I'm just really excited to see some of the things that are coming out of the reproductive health guidelines and the way that the different groups are working to get the message out. I think as a pharmacist, but also as a patient, it's just really exciting to see the work of that group coming to fruition, and that we're, I think, making a positive impact. We're working in the right direction to get this information out to both patients and providers. So that's really exciting to see.
Well, I think we've really seen an explosion in this area of rheumatology with a lot of research in recent years. And I think the earliest research was looking at safety of medication in pregnancy and in breastfeeding. And of course, that is ongoing, especially with all of the new medications that are coming out year by year. But I do think that in addition to that, we've seen a lot of research looking at patient understanding, trying to understand patient evaluation of the information that we as physicians present to them, because it isn't enough to just be able to say this drug is safe, this drug is not safe. We need to understand how patients perceive that information and what might be limiting them from feeling comfortable taking a medication during pregnancy or breastfeeding. And again, a lot of qualitative research looking at the impact of all kinds of factors on patient decision making. And I think that will ultimately lead us to a better way of presenting this information to patients.
Great, Lisa and Whitney, thank you so much for your time. This has been a really fascinating conversation, and I hope to chat with you guys at a later date where, maybe we'll have some updates about reproductive health. Thank you so much and have a great one. What great conversations. Take-home points for me from today's episode is that both physicians and patients struggle to understand the safety of medicines during pregnancy and lactation. I'm hopeful that the recently published ACR 2020 guidelines on reproductive health in rheumatic diseases may help to improve knowledge for all stakeholders. I guess we'll just have to wait and see if that happens. Anyways, thank you all for listening. Don't forget to subscribe and rate this show at acronair.org, Apple Podcasts, Spotify, or on your favorite podcasting app. Until next time, please make sure that you and your patients receive the COVID-19 booster vaccinations. And of course, please stay healthy.